Welcome to a deep dive into a fascinating case report published in Veterinary Record Case Reports. This study, titled Clinical Course and MRI Lesion Progression Over 4 Years in a Dog with Final Diagnosis of High-Grade Oligodendroglioma, presents a unique look at the long-term journey of a canine patient with a complex brain tumor. The authors, Fabiana Graziali-Tomazzi, Veronica M. Stein, Anna Everman, Felix Menezes, and Ariana Maialini, from the VetSuisse faculty, University of Bern, Switzerland, meticulously document the clinical, imaging, and pathological findings in this case, offering valuable insights into the diagnosis and management of canine gliomas. This report stands out due to the unusually long survival time of the dog under palliative care, challenging our understanding of these tumors and their progression. Canine gliomas, which include astrocytomas and oligodendrogliomas, are the second most frequently observed primary brain tumors in dogs, accounting for approximately 37% of such cases. Oligodendrogliomas are the predominant subtype, making up around 22% of primary brain tumors in dogs. These tumors are frequently seen in brachycephalic breeds, and tend to affect older dogs, typically around 8 years of age, although the age range can be quite large. Gliomas in dogs, like in humans, are associated with unfavorable outcomes, and current data on survival times varies widely, influenced by the chosen treatment approach. This case report aims to contribute to a better understanding of these tumors by detailing the progression of a high-grade oligodendroglioma over an extended period under palliative treatment. The subject of this report was a 9-month-old female Cavalier King Charles Spaniel. The dog was presented with a 3-month history of sudden vocalization, shivering, and phantom scratching. Initial treatment with robenacoxib and gabapentin, provided by a referring veterinarian, resulted in clinical improvement. Upon physical examination, the only notable finding was a mild ocular discharge. Neurological examination revealed lumbar pain, with no further neurological deficits. This led to the suspicion of a pathology causing diffuse pain, potentially related to the head and spinal areas. To investigate further, the dog underwent hematology and serum biochemistry tests, which were unremarkable. A brain and cervical magnetic resonance imaging, or MRI, study was conducted. This initial MRI revealed a large intra-axial cystic lesion in the left frontal lobe. The lesion showed multiple enhancing thick septa and an irregular thin capsule with focal thickening, as well as multifocal areas of signal voids on a T2 weighted image. The fluid within the lesion mirrored cerebrospinal fluid in all MRI sequences, with a small fluid level also noted. There was mild perilesional edema, and the mass effect resulted in a midline shift, distortion of the left lateral ventricle, and mild caudal transtentorial herniation. Additionally, signs of caudal cranial fossa crowding, mild cerebellar transforaminal herniation, and cervical spinal cord syringohydromyelia, suggestive of Chiari-like malformation, were observed. An abdominal ultrasound ruled out parasitic infestation. Cerebrospinal fluid analysis showed an increased total nucleated cell count, but no evidence of albuminocytological dissociation. Based on the MRI findings, a primary brain tumor, such as a glioma like glioblastoma multiforme or anaplastic astrocytoma, was the main consideration. However, a cerebral hydatid disease, porencephaly, and other congenital cystic malformations were also considered, though less likely. The owners of the dog declined the offered options of stereotactic brain biopsy and possible radiation therapy. As a result, the dog was discharged with palliative treatment that included oral gabapentin, omeprazole, and dexamethasone with a tapering schedule. Now, let's turn our attention to the long-term follow-up. Approximately 3 months after initial presentation, the dog was re-evaluated and was still on dexamethasone and gabapentin. The owners reported a noticeable improvement, particularly a reduction in phantom scratching episodes. 2.5 years post-initial presentation, the owners noticed a relapse of pain when they tried to discontinue gabapentin. At this time, the dog was otherwise stable under the existing medications. A follow-up neurological exam was unremarkable. A second MRI, 2.5 years after the first, revealed a decrease in size of the lesion and perilesional edema. There was an increase of the signal voids within the lesion capsule and septa on T2 star-weighted images. There was also a reduction in mass effect, mild brain atrophy, and no change in the Chiari-like malformation abnormalities. Due to the stable clinical condition and lack of lesion progression, the initial suspicion of a high-grade primary brain tumor was re-evaluated and a congenital cystic malformation was considered more likely. The dog was discharged on gabapentin and dexamethasone was discontinued. The dog remained stable for more months, but suddenly presented with seizures 4 years and 1.5 months after the initial presentation. At the final presentation, the dog had an acute onset of single, self-limiting seizures. The clinical and neurological examinations were unremarkable and blood work only showed mild leukocytosis. The dog was started on oral anti-seizure medication, imepatine and levetiracetam. Despite treatment, the neurological condition rapidly deteriorated over less than 48 hours, leading to cluster seizures and stupor. The dog was given emergency treatment with intravenous mannitol and phenobarbital, resulting in temporary improvement, but ultimately suffered from cardiorespiratory failure and death. A post-mortem MRI showed a marked enlargement of the left frontal lobe lesion with midline shift, and caudal transtentorial and foraminal herniation. The neuropathological examination revealed significant findings. Macroscopically, there was a large, variegated, beige and red mass extending from the thalamus to the frontal lobe in the left hemisphere, with a severe shift to the right, extensive necrosis and cavity formation. The mass also had multifocal areas of hemorrhage and necrosis. Histopathologically, the mass consisted of a homogeneous population of round cells, with round, hyperchromatic nuclei and scant cytoplasm with an oligodendrocyte-like appearance in a myxoid matrix with delicate branching capillaries. There were also multiple mitotic figures noted. Immunohistochemistry confirmed OLIG2 nuclear positivity and GFAP positivity in reactive astrocytes and some neoplastic cells. Additionally, there were multiple areas of necrosis with palisading neoplastic cells and microvascular proliferations, as well as multiple drop metastases in the subarachnoid space and ventricular system. The final diagnosis was a high-grade oligodendroglioma associated with subarachnoid and intraventricular drop metastases. Let's pause to describe the figures presented in this case report. Figure 1 shows the MRI of the brain at initial presentation, parts A to D, and at follow-up 2.5 years later, parts E to H. These are transverse images at the level of the frontal lobes, and mid-sagittal views. Parts A and ERT1 weighted images after contrast, parts B and F are T2 weighted images, and parts C and G are T2 star weighted images. Finally, parts D and H are mid-sagittal T2 weighted images. The figure shows that the left frontal lobe lesion has capsular and septal enhancement. The content is hypointense on T1 weighted images and hyperintense on T2 weighted images, and has multiple signal voids on the T2 star weighted images. It also shows typical changes associated with the Chiari-like malformation and cervical syringohydromyelia. The follow-up MRI in this figure shows that the lesion has overall reduced in size with an increase in signal voids along the capsule and septa. Figure 2 shows post-mortem MRI images 4 years and 1 month after the initial presentation. Parts A through C are transverse images of the frontal lobes in T1, T2 and T2 star weighted images, respectively. Part D is a mid-sagittal T2 weighted image. The lesion is enlarged with a large central solid component showing mixed signal intensity in T1 and variable hyperintensity on T2 weighted images, as well as the multiple T2 star signal voids. There is also deformation of the third ventricle and caudal transtentorial and transforaminal herniation. Figure 3 is a transverse section of the formalin-fixed brain, showing the large space-occupying mass in the left hemisphere, severe midline shift to the left, and extensive necrosis. Figure 4 shows histopathology of the intra-axial mass stained with hematoxylin and eosin. Part A shows densely packed neoplastic cells with a large area of necrosis and hypertrophic vessels. Part B shows the homogeneous population of round cells with oligodendrocyte-like features and delicate branching capillaries. The discussion section of this report is insightful and contextualizes the case within existing knowledge of canine gliomas. The authors discuss that gliomas are the most common primary brain tumor in dogs and humans, and the similarities they share. They point out the variability in MST, or median survival time, due to the lack of wide-ranging estimates for these tumor types, differences in the time of diagnosis, and lack of standardized care. Treatment options and their impact on survival are highlighted, and that these are often limited by owner compliance and financial constraints, as well as the availability of therapies. Palliative therapy for dogs with confirmed intracranial glioma, they mention, has a MST of approximately 25 days. Radiotherapy is a better therapeutic option, with a MST up to 698 days in some cases. Chemotherapy is also discussed as a sole or adjuvant treatment, with a lack of representative data on MST due to significant variation in treatment protocols. This particular case is notable because the dog survived 1,505 days after initial presentation under palliative care, which greatly exceeds the longest survival time reported in dogs diagnosed with a high-grade oligodendroglioma. The authors theorize that the initial lesion may have been a low-grade tumor that progressed to a high-grade lesion. It is also possible that the high-grade oligodendroglioma arose within the cystic lesion. The report underscores the value of MRI in identifying canine brain tumors, noting that gliomas typically present as intra-axial mass lesions with varying degrees of perilesional edema and contrast enhancement, with more enhancement associated with a higher tumor grade. The specific features of this case, including the irregularly thickened wall and septation, the T2 star signal voids, and the contrast enhancement, initially pointed to a high-grade glioma. The initial differential diagnoses and other possible causes of the symptoms, such as arachnoid cysts and Chiari-like malformation, were considered and discussed. In this case, the dog's primary symptom was episodic pain, which is a less common initial presentation than seizures for gliomas in dogs. The authors also discussed that pain, like the pain described in this case, has been described as a feature in dogs with a forebrain oligodendroglioma. The report concludes that the initial diagnosis was challenging given the stable clinical and radiographic findings over the first 2.5 years, highlighting the difficulty of accurately diagnosing brain masses based solely on MRI and CSF analysis, and the importance of biopsy for correct diagnosis and treatment. The case also demonstrates that a long survival time is possible with palliative therapy in these tumors. It emphasizes the usefulness of frequent MRI follow-ups to assess brain lesions when a biopsy is not possible. The authors underscore the fact that the survival time was remarkably long, and that this clinical picture does not fit with what would be expected of a high-grade oligodendroglioma. They also mention that it is possible that the tumor was initially low-grade and then progressed to a high-grade tumor. This case report serves as an important reminder that despite our understanding of disease, individual experiences may differ from expected patterns, and that a regular evaluation of clinical and imaging findings will help the clinician to make a more informed diagnosis and prognosis. From Vet Neurojar, keep those minds inspired, hearts light, and tails wagging.